All right, so it is 12:01, so let's go ahead and get started. Thank you everyone for taking this hour to join us. This is our third PCBH SIG meeting of the year. We hope to have a very helpful conversation surrounding chronic pain management and primary care. I have a few announcements before we get to that panel discussion. Quickly, again, if you want to, if you are new to CFHA and want to be a part of the PCBH SIG, you can go to the CFHA website, go to the PCBH SIG section of the website, and there is a link that you can click on to be a part of the PCBH SIG. It's open to all CFHA members. Again, keep an eye out for our newsletter. It actually just went out earlier this week. We tend to send those out as we are approaching our webinars, which are done every other month. So it should be sitting in your inbox if you want to browse through that newsletter. Just a reminder, here are our leadership for the PCBH SIG in the next year. And I want to open the floor briefly to, does anybody have any job announcements that they want to make or any other announcements, learning opportunities that they want to share with the group while we're gathered here today?
Anyone is interested in working in the California wine country, Santa Rosa Community Health has 5 new positions for behavioral health clinicians. We are opening up our PCBH program.
Sounds like a wonderful place to work. Anyone else? All right. Again, if you are looking for a job or just open to jobs, you can also visit the CFHA website and look for job postings. There is a specific place on the website where you can see any open postings. And I wanted to put a plug in today also for the new certification that CFHA put out, the certification in BHC ORS administration course. This certification is designed really for any site that is implementing the PCBH model. It includes training on how to use the observation rating scale and provides an opportunity to observe a BHC in action, enabling participants to kind of offer direct feedback. So if you want to learn more about this course, if you want to scan that QR code, do so, and that'll take you to the website that provides you more details about when this course is going to take place, the dates, how many there are, the cost associated, the CEUs, and all that good stuff. So you can go ahead and scan it if you're interested in learning more about this. There was an email also that went out that you can look for as well. Just as a reminder, this is our third meeting of the year. We have 3 more coming up. Our next one will be August 7th, and it will also be a panel discussion on obesity managed in PCBH. Our October meeting will be in person at the conference, and we are working on an exciting topic that we can focus on during that in-person meeting. And then we'll have one at the end of the year as well that will focus on perinatal mental health. And lastly, just as a reminder, we do have the SLIP group that is housed under PCBH. They are under new leadership, so we're actively working with them to try to support their programming. But if you have any questions about, their events or their goals for the coming year, you could reach out to Dr. Marrero or Feliciano, who are new leadership for the SLIP group. Another announcement, we are actively looking for mentors or individuals who want to receive mentorship. If you were previously a mentor and still want to be a mentor, we have a new form that we have developed to gather information so that we can help match individuals, so match a mentor with a mentee. So if you are still interested in being a mentor, please visit our website for the link or scan this QR code so that you can fill out the new form just to get an updated list of individuals who want to provide mentorship. And of course, again, if you want to be a mentee and want to receive mentorship, there will be a different form for you to fill out. You can scan that QR code or visit the PCBH SIG website to access the link to the forms. All right. And lastly, before we get started on our panel discussion, we love to hear your feedback. We try to program events and content based on your feedback. And so if you still have not filled out this survey, this will help us determine programming for the next year and also determine events that we hope to plan for the conference if you are going to be in attendance. So please let us know what you would like. We really want to support our community and address your needs by providing content that would be most helpful to you all. All right, so to get started, so today we have a panel discussion. We have Drs. Cassano, Hallstrom, and Coldagelli. Did I say that correct, Matt? I hope I did. My apologies if I didn't. They're here joining us today to just have an interactive discussion on chronic pain. Chronic pain is, something that is very relevant to primary care. It's challenging for our PCPs, it's challenging for our patients, it's challenging for BHCs. And so we wanted to provide this opportunity to learn from others on how we can address this issue. And so just a little background information on our presenters. So Matt is a licensed clinical psychologist who works as the lead behavioral health specialist for One Medical Seniors in Arizona. He has worked in primary care using the PCBH model for 3 years, starting with Iora Primary Care, which was eventually acquired by One Medical. He operates predominantly from an ACT perspective and loves helping patients commit to value-focused behavior. Specific areas of interest for Matt include interventions focused on increasing healthy behaviors in patients with chronic pain, diabetes, and cardiac health problems. Dr. Cassano is a licensed clinical psychologist who serves as the director of behavioral science for the Crozer Health Family Medicine residency. In this role, he develops and implements a behavioral science curriculum for the residents, as well as provides care for his own patient panel and supervises doctoral level psychology students in their training. In his clinical work, he specializes in treating co-occurring mental and physical health conditions, namely chronic pain, insomnia, weight loss, nicotine cessation. Additionally, he serves as an adjunct professor in the Master's in Clinical Counseling program at PCOM. And Dr. Hallstrom is a licensed clinical psychologist at One Medical. She has spent the last 8 years of her career working in primary care, where she has led groups, individual sessions, and educated care team members on evidence-based behavioral interventions for chronic pain. She has also used her expertise to develop and implement new chronic pain training for behavioral health team members and a referral pathway for patient care. So let's go ahead and get started. I'm going to turn it over to our facilitators, Rachel and Stacy.
Awesome. Thank you so much, Gabby. So I think before we get into the panel discussion, we have a few polling questions that we want to, give to the audience just to kind of gauge what the knowledge is about treating chronic pain in a primary care setting. Hannah, are we able to pull up those polling questions?
Yep, there we go.
Okay, wonderful. If everyone will take just a minute or so to fill that out, and then that way we kind of have an idea of where the audience is at. And then Hannah, will we be able to pull those up on the screen?
Yes, I
Okay.
will. Once I end the poll, I can show you all the results. I'll give you all about 10 more seconds to get those last responses in, and then I'll turn that over. All right. Should all be able to see that now.
Awesome. Okay. So it looks like we had 2 questions. So the first question was your level of experience treating chronic pain in a medical setting. It looks like a good chunk of our audience of us have some amount. So we have a little bit of background of what that looks like. And then the confidence in delivering these interventions. Looks like everybody's kind of in the middle on their confidence level in treating this. And so now I'd love to check in with our panelists and kind of present the first question. So we'd love to hear from each of you. How did you get to the place in your career where this was your main focus, where chronic pain in a medical setting was your main focus.
All right, I'll go first because I think Mark and Kirsten have better answers than me. I think it was kind of not something I didn't expect, something I kept hearing before I came into primary care. Would so often notice doing traditional specialty mental health, my patients were just experiencing either somatization of their distress or just running into injury. And that was a huge barrier to a lot of the treatment planning we were trying to do. And I just kind of threw up my hands and said, well, I guess you should talk to your primary care provider. And that was all that ever happened. There was never any integration of it. And so it kind of fell away. And then now I work primarily, my clinical care is with older adults. And so many of them are experiencing up and down acute pain, but of course, many of them have developed chronic pain, whether it's diabetic neuropathy, chronic lower back pain. And I just reached the point where I kind of finally realized I can't really talk to this person without talking about the elephant in the room. So I better figure out what the heck I'm supposed to do about this. And so I am very grateful to have some stellar colleagues and have done some CEs and really read into this and realized it dovetails very nicely with the basic principles of ACT, this idea of acceptance and commitment and recognizing pain in its place and not making it a focal point. There was also, of course, a large push to get our patients to pursue other pain management options that were opioid-free, that were going to be more sustainable. And so I saw a real opportunity in our organization for behavioral health to help support our strategy as an organization in increasing care. So it just kind of kept coming to me until I couldn't ignore it. And so I gratefully leaned in instead of ran away.
So for me, when I first got immersed in the integrated environment early in my graduate training, you start to get familiar with what are the common issues that are coming in. What are the issues, what are the concerns that physicians are consulting most about, or just frustrated the most about. And it was evident pretty early on that chronic pain was just this everlasting, kind of ever reoccurring issue that was there. And I was excited to learn that there had already been some evidence-based treatments developed to help address this from the behavioral health side. And so I started to get trained. I was fortunate enough to work in a clinic that had a very dedicated pain treatment clinic that was fully integrated. It was a patient-centered medical home that specialized specifically with pain management in the clinic in a VA in Pennsylvania. And I honestly just fell in love with it. I mean, when you really get to see the impact that these treatments have on people's quality of life, it's really validating and reinforcing for us as the providers too. And I was fortunate too to also see it both on that individual and group level, where patients were able to come together and be with other people who are struggling in similar ways. You really start to see and understand how these treatments can have a truly profound impact on people's lives.
I would say that my health psychology background, like my training in school, didn't really have a lot of focus in chronic pain, which I think is pretty normal. So I got a lot of my experience from my internship. I kind of had to dive headfirst because my internship was at a chronic pain clinic. So this clinic was a multimodal approach. So patients would come to this clinic 5 days a week for 8 hours. After they had been injured on the job and then spent many years doing different types of treatment, surgeries and all sorts of things. And they would come to this clinic eventually, years later, still with pain, kind of almost it felt like a last resort. Like they knew they couldn't have any more surgeries. Like they were just at the point where they had to figure out how to cope with their pain. So they would come to this clinic and they would get physical therapy, occupational therapy, nursing and nutrition counseling. They would see a doctor, they would be a vocational counselor. And then they also had behavioral health classes, individual sessions. And as an intern, I had the opportunity to go through this program with them on some days where I actually got to be in physical therapy with them and do in vivo interventions while they were, battling the fear thoughts that come up about their pain, or they, were struggling with a flare up that day, whatever it was. I got to actually implement interventions and got exposed to the Beverly Thorne manual for chronic pain, which is more CBT focused through that program. And so that was a really intensive year of learning about chronic pain, and I am so grateful for it, because after that, and I've mostly worked in primary care and a little bit in oncology, but chronic pain is everywhere. It is not just siloed in chronic pain clinics. And so I work in the same organization as Matt. So I work specifically with seniors in the geriatric population, and our patients, the most of them have some element of pain or chronic pain from one or more of their conditions. So pain it comes up every single day. And it is very prevalent in our patients' lives. So being able to use the skills I learned that year and implement them into more of a primary care setting has been really fruitful, from implementing groups to doing short interventions with visits, to teaching our colleagues on the care team about chronic pain, how behavioral health can have an impact, and coming at chronic pain from a multimodal standpoint has been really helpful and eye-opening.
That's great. Thank you all for sharing how you got started and how this became an area of focus for you. Next question would be, what misconceptions most frequently surround working with patients living with chronic pain?
I would say one of the biggest misconceptions that I encounter is that all patients with pain are seeking pain meds, and that they're addicted, or that they're, just trying to get opioids. That is just really, really hard to hear for my care teams. And that's the first thing that often comes up for care teams. And so part of my role is a lot of education on patients who are asking for pain meds are still in pain, right? And a lot of times they are just taking something that's going to help them manage their pain a little bit better. And I also think it's really important for us in the medical community to acknowledge that we played a role in patients wanting, needing, and being addicted to opioids. But I think the misconception is that they're just, malingering or exaggerating their symptoms to get a medication. When the reality is, like, they're in pain and they want care, and they want to be heard, and they want to be helped, and they want to live a better life than they're living today. And so it's really important to remind our teams of that.
Yeah, I certainly resonate with Kristen there, and I also will say that there's a fair amount of I've had a fair amount of experiences too with providers, both on the medical side and more so even on the behavioral health side, of this belief that the interventions we can provide through these treatments that are established may not be of interest to people with chronic pain, because they are looking for a more effective and efficient fix. And I've had some people I've trained even come back to me kind of reporting an apprehension, or even just a complete what's the word I'm looking for? They haven't actually applied certain techniques because they just assume a patient may not be open to it. And then when they actually provide the proper education, provide good explanations and justifications for what we can do, it's amazing how people can become more open to the possibility. And from that openness, we really do see a lot of the change. And so I really stress the importance of not assuming anything on the part of our patients, kind of giving them an opportunity to decide for themselves what's going to work for them, because these treatments really do work.
I think too, there's just echoing for sure what Kirsten and Mark have said. I think the other thing I've noticed, not so much in my personal practice, but just keeping up with research around health equity, there's definitely a lot of misconceptions about different people of varying backgrounds and the degree of pain tolerance. And just looking at kind of macro levels, what kind of interventions are typically offered to different patients, whether it's based on age, race, sexuality. And there's just opportunities, I think, to really bring in both culturally focused and holistic interventions. And that's why I think really meeting these patients with a biopsychosocial approach allows them to bring in their own perspective and opinion and history with pain, their understanding of what it means to experience pain. I think that maybe the misconception is that pain is pain is pain. It's a nerve sending signal to the brain. I have to suppress that nerve, and then we go from there. And, I think we've realized, to Mark's point, Kirsten's point, like we've sold something that isn't sustainable and is dangerous, and we do have enough research to show this stuff works. This isn't snake oil. This isn't, some magical words. These are very well established interventions. And I think providers who I've worked with who've bought into that, it's just such a joy. I try to be empathetic to those who just haven't quite gotten there yet, because we're asking them to really reframe a significant amount of their training, and also kind of take some of the role out of their hands, which is uncomfortable for some of them. And so I would say that the more we can share just wins and success and research, the more we can undo these misconceptions.
I agree. Hi, it's Dr. Michelle Nett. I also wanted to provide a comment. Also with pain management, just looking also at the culturally sensitive tools that we're utilizing to assess pain with these clients. I'm just making sure that the tools are pretty much differentiated for these specific populations that we are addressing, making sure that we're using state-of-the-art and modernized tools to assess. And like someone was saying earlier, being sure to not stereotype and judge, because mental health and mixed with, of course, substance abuse and so on and so forth, and integrated care, it's a very important topic that should be addressed in today's community.
Yeah, I absolutely agree. I mean, I think the stigma with chronic pain is really high. And I think patients feel that. I mean, the number of patients who have told me, like, no one believes my pain. They just think I'm a drug seeker. All of those things, like, they feel the stigma that is built up against them. And I hope that we all can do our part to start to break down that stigma and implement strategies that are helpful to them and like actually culturally appropriate.
I'm so sorry, I fell off the meeting, but do we have anyone else from the audience who would love to either comment or share any reflections that came up for them while the panelists were sharing? Go ahead and feel free. You can unmute yourself and share what you would like to say.
Well, I worked with chronic pain patients for my dissertation, and I also live with chronic pain. And I think one of the biggest lessons that I've learned through all of that is that giving the patient a sense of control is really, really important. That if they feel that they have what I would call a toolbox, and different tools work for different patients, but at the end of the day, if they feel like they can pull a tool from the toolbox, whether that's meditation or relaxation or sleep hygiene or nutrition, it differs for every patient, but that they can help themselves, that's tremendously powerful, because they see us maybe an hour a week, and the rest of the time they don't see us. And so they need that self-sufficiency. That was one of the biggest things I learned.
That's really great perspective. Anyone else?
I have a quick question.
Mhm.
One of the things that I've struggled with is helping patients move from the very physically focused chronic pain to understanding the interplay with somatic chronic pain. That shift, it's a paradigm shift in your mind, and I think a lot of the patients that I work with, often haven't graduated elementary school yet, right? We're working with adults patients who have a 4th grade education and aren't able to kind of grasp that complex paradigm shift. Do you guys have any suggestions for that, therapeutically?
Something I've done, and you want to make sure you do it, I like to inject a bit of humor, but also make sure that it's something that makes a patient feel like their pain is still real. So that's the balance, I think, that's trying to be driven. It's to get the idea that Although the source of a feeling is up for debate, the feeling itself is real. So sometimes, when I'm being a little mean, I'll vividly describe a very tasty sounding chocolate chip cookie and ask the patient to tell me what their response to that, to my words are. We'll do it meditatively and they'll say, well, yeah, my mouth is watering. I can almost smell it. And they say, yeah, but isn't that wild? There's no cookies here. And that's how powerful our brain is. That's how amazing our brain is. And it's also how pesky and frustrating our brain is that your feeling right now is real. I believe you. I believe that you smell what you smell. I believe that you have a watering mouth. And I'm sorry to say I don't have a cookie for you, right? Like, I don't try not to do that with my patients with diabetes because they don't take it as well. They get a little upset. But I think that idea that just introducing that paradigm of that's what it means to be human. That's what it means to have the vivid imagination, like the vivid processing power of a brain. You want to avoid like imagination, right? But to say, hey, this is real. This is still an experience that you get to deal with. But I think even go back to Nina's point is that's when you hopefully then pivot it toward control and to say, hey, you can also imagine a really pleasant experience that can start to turn down that really high frequency nerve signal that's coming into your brain. And so you do have the ability to use this to your advantage. So I try to pivot it as this is the thing that's getting you into this pickle. But the good news is if you kind of grab the wheel and do these things like meditation, journaling, such, you can kind of take that power back in a little bit and give yourself those positive feelings.
Absolutely. I mean, a big thing that I focus on a lot, and this actually kind of plays into, I think, what our next question will likely be, is just helping people shift their relationship to pain. I think we're trained from a young age to avoid it, for good reason too. But pain is a warning signal, right? And if we didn't have it, our life would actually be a lot harder. But when you say that to somebody who's dealing with daily chronic pain, it's not the most validating thing to hear. And yet, if we can help people begin to shift the relationship to their pain as something that isn't necessarily the enemy, to Matt's point, that volume knob starts to drop a lot. And this just is basic tenets of the gate theory of pain management, right? It's kind of incredible, and I think the reality too is we exist with discomfort day to day that we accept. I think about examples of like eating too much really good food or exercising, right? These are forms of pain and discomfort that we tolerate because there's a secondary gain. And while chronic pain may not necessarily have that same payoff, quote unquote, it teaches us that we are actually capable of living and thriving with discomfort all the time. And if we can change our mindset in that way, people start to realize that their quality of life can go up, that pain isn't kind of the end of their life, quote unquote, that way.
Yeah, I've found that because pain is such a physical experience for patients, I agree, Maya, it is really hard for patients to sometimes switch from like how physical this pain is to even talking to a behavioral health person, because they're like, how would talking about this physical thing make me feel better? Which feels really real, right? This pain is real and it's physical and consuming. So the way I sometimes try to talk about it to at least get that buy-in to open the door to be able to talk about these other things is I describe the base or the etiology of their pain like fire, right? So I might not know what is causing the fire, and it might not be something psychological, right? There's something real causing that. But there are elements in our life that are like putting fuel on the fire and making the fire bigger. And so our work together is going to be taking away the fuel so that the fire comes back to a level that is more manageable. I'm not saying we're taking away the fuel and the fire is going to go away. But what I'm saying is that we're going to take away those flammable elements that are making the fire so huge and so consuming that it's overwhelming. Let's bring it back to the base level of fire. It's taking away these things that you and I are going to talk about. And sometimes that shift sometimes helps people just with the buy-in. And it's a little bit validating of like, yeah, I'm not saying that this is all in your head. Like your mind is not creating the fire, right? Because that can feel really invalidating. But to Nina's point, like, let's bring back some of that control. Like, let's bring back some of that power that there are things that I can do to manage this and to bring it back to a manageable level, to turn down that dial. Because a lot of times it feels like our body and our pain is controlling us instead of the other way around, and wanting to bring back that sense of like, there is something I can do. You might not get to zero, but at least it's something that I can do so that I can engage in life in a way I want to. I can go to my kids' soccer game. I can do laundry, you know, whatever it is. Let's take away the fuel from the fire, so we just are dealing with the fire as it is. So that's kind of my strategy to kind of open the door for that. Hope that.
So I wanted to chime in just for a few minutes. You know, some things that I've heard so far is this that was sort of common amongst our panelists, is this push to acquire skills and knowledge about how to treat chronic pain, to feel confident and comfortable doing so, and not just to treat it, but to treat it in a way that fits in the PCBH model. And then also having this level of support at different levels, leadership, organizational support, that transitions away from this kind of unidimensional view of chronic pain management to this multidimensional approach to viewing and treating chronic pain. And so I think people, of course, want to know, what are these skills? What do I say? What do I do? How do I work with people? And we have one of our attendees here, Dr. Hunter, who just messaged me about a protocol for treating chronic pain in PCBH. So I'm going to quickly turn it over to him so he can share this amazing resource with the group.
Yeah, thanks, Gabby. I mean, the things you're talking about are the things that in my previous job that we saw as being skill set deficits for almost all BHCs working in this model of service delivery. And so in my previous job, I was the lead for the DoD for rolling out primary care behavioral health services. And so we had these services in over 300 primary care clinics. And we knew that we had people coming in with chronic pain that was being ineffectively treated or just not even addressed at all. So what we did is we developed an evidence-based brief treatment for chronic pain in primary care manual for BHCs. Not only did we develop that manual, but it's flexible and it has different modules with basically our recommendation was, hey, do the first 2 of these modules, and then you can do whatever other ones seem to best fit what the patient brings in. It has patient handouts. It has checklists for the providers for particular appointments. It has apps. It has all the guidance that you need. And so we wanted to make it as user-friendly as possible. You know, something that somebody could just pull off the shelf and start doing. At the same time, we knew that people also need training on that. So we also trained, and it was part of our standard care. Each new BHC got trained. Well, they went through the manual, they did skills training on this manual, and then they had mentoring calls afterwards where they could address any other problem that was coming up, and then they introduced new topics. And so I just got the okay today to be able to distribute these materials. And so people can use these however they want. I think I've done this correctly. I'm about to send to everyone, not only the manual, but also a PowerPoint presentation that goes over things. I think the mentoring calls, I mean, you can contact me individually if you are a trainer and you want to kind of set this up. But I think what I'm about to send would be appropriate for everybody that's on this call. And feel free to share this with whoever you want. The one request that I got is that if you change anything in this manual or this PowerPoint, just take all the DHA DoD logos off it, because then it's no longer a DoD kind of approved product. But that's simple. You just take the branding off of it. So I'm going to send this. Let's see if it'll go. You know, old guy, new technology, lack of use. It's like back in the day. Oh, I saved a file to my 5-inch floppy disk. Yay. Okay, did everybody get that? All right, so please feel free to use that. And I think what we liked about this is it wasn't, you must do this, all of these with all patients, everyone that walks in, but it goes through giving very specific guidance. And I think in the real world, I mean, we wanted to have some standardization. I think if there's warranted variance to go outside of this, then you do that. And then you see, did that warranted variance give you the results that you're looking for? So, here's your baseline, here's your recipe book. Pick and choose from that what you think is going to work best for your patients and measure that. And we tried to incorporate this into a clinical pathway. In fact, we put it in our primary care providers. They had to ask a specific pain question, and then we got a pop on that one. Then they were actually trained on how to bring the BHC into this. So, think about how you might want to do this as part of a standard pathway, even starting off with, one provider or one pod of providers as opposed to the whole clinic, somebody who's interested in this. And so good luck, and feel free to message me with anything if I can help you in any way, or Gabby knows how to get a hold of me. You can contact her and she'll track me down. Thanks.
Thank you, Dr. Hunter. That was very helpful. That's exciting to know that we have, this training tool to help provide those additional skills so that we can work more effectively with this challenging population.
Wonderful. That is an amazing resource. And I think you're right, Dr. Hunter, like we could all benefit from using something like that. Kind of leading from the last question, about what do you find like are some common difficulties and like challenges that you face? I know the three of you have already hit on some of it, but are there specific things that you see come up time and time again, that make sometimes the scenarios, difficult or it just an interesting case to work with?
I just want to say to start by saying, Dr. Hunter, thank you for this that you sent out. Man, I wish you had sent that out last year. I had to do something like this on a much smaller scale, it sounds like, than you did, and training all of our behavioral health specialists and creating a referral pathway and stuff. And man, this would have been very helpful at the time. So I'm glad to have it at all. So thank you for sending that out. But as far as common things I encounter, one thing that I feel like I encounter, a lot is patients with chronic pain talking about the things that they don't feel able to do anymore, and really grieving that. Like patients who are, talk about like, oh, I used to be an avid golfer, or I used to, do XYZ. And it's really hard when they're fixated on those things, like I can't do this, I can't do this, I can't do this, to get them to kind of switch gears a little bit. And this is where I feel like ACT comes into play a lot, and I feel like it's really applicable. So I use a strategy of talking about like what's it called? A limitation circle. So I draw it out for them, and I draw this big circle of how their life was, whatever years ago that they're talking about. They used to be a golfer. And I talk about how there's lots of things that used to be in their circle, like golf. But there's also the things that were outside of their circle at the time that they didn't maybe really care about because they had so many fun things inside their circle. Like for me, dunking a basketball has always been outside of my circle, but it's never really bothered me because I could do other things. Like dunking a basketball for me was not all that important. But with their chronic pain, their circle has started to get smaller. And so now there are certain things that are outside their circle that used to be inside their bigger circle. And so then we have this conversation of, okay, well, how do we manage that? Do we either find things that were outside their circle that they used to love doing and figure out how to modify that so they can bring it into their now size of circle? Or do we focus on the things inside of our circle that we can do and really hone in on that? And every time our mind is stuck on this outer circle, like I can't do this, I can't do this, I can't do this, how do we get our mind to switch gears and focus on the things inside our circles so that we can live a full life, even if the circle size is a little bit different, right? So it's either modifying or pacing or finding new things, just really talking about different strategies so that their life isn't focused on the things that they can't do anymore, even though that might still feel like reality for them.
Yeah. Yeah, I mean, I definitely approach chronic pain treatment through a CBT perspective, but I find that the ACT approach definitely is a wonderful partner in exactly the situation, because this is something that I encounter a lot too. And to kind of carry what you're saying forward, there is always the option for modification. The challenge that I encounter, though, is people being unwilling to modify. If I can't do it the way I used to, I'm just never going to do that. And then we find ourselves kind of in this like kind of pit of despair, right? And so using ACT principles can be really beautiful here, in addition to just basic cognitive reframing skills to help a person understand that, well, yes, it is certainly sad that you can't play golf like you used to. Or a case that's coming to my mind is a woman who used to dance regularly with friends and now is unable to do that. And the idea of going there and sitting on the sideline watching her friends dance was depressing for her. But through the utilization of other techniques like pacing, as an example, she was able to get back to dancing, but in a way that actually worked with her body. And the process of doing that allowed her to let go of that hold she had on herself, where if I can't do it the way I want to, then I won't ever do it. And that's what ultimately really helped propel her forward in recapturing a higher quality of life. But it's a challenge for a lot of patients, this kind of all or nothing thinking around what they can and can't do.
Yeah, I would echo those. Definitely in the, in the patient practitioner experience, I've had that as well. The difficulty for me is ongoing effective communication with the provider about the plan, about, what activities can we feasibly recommend. Like to Kirsten's point, like making sure I have within my competency scope of practice an understanding of what the circles probably could actually look like. Getting that medical communication and expertise. And then even thinking, okay, what's the plan here? Are we pursuing a high value procedure? Is surgery expected to be effective? Should we be counseling other alternatives? And just making sure that there's that constant and consistent and effective communication, whether it's within the primary care clinic, whether it's with ortho. There's always challenges getting records and such. That's an ongoing challenge. And so I think finding that mixture of being bold and challenging patients to modify while also remaining ethical and conservative in the sense of, you don't want patients to push themselves. I ended up being okay. An old patient of mine, when I was first really eager about motivational interviewing, she said, I really want to fix my roof. I really want to fix my roof. And I said, okay, what would it take to fix your roof? I come back next week for the session and she's in a cast because she fell off her roof. And so, I knew it wasn't my fault, but there's just the reality of, we are approaching risk in this. And I think I understand, and because I still experience it, if you're just dipping your toe in this, you would hate to really push your patients to do something that results in further injury. And at the same time, we would be doing our patients a disservice by ourselves falling into the escape avoidance paradigm of what we're worried about doing that is actually beneficial. So I think knowing where to land as best we can and getting that consultation clearly from medical providers who are involved in the case is a constant challenge, but it's definitely worth it, because then you can be really confident in the circle you're helping your patient set, or in the expectations and pacing, like Mark said, that you're supporting in the intervention.
Yeah, I'll echo that, Max. That's a really good point. When training BHCs or BHSs, that is the fear that comes up a lot, is, well, what if they, I'm telling them to do something and be more active and it's actually re-injury? Because with acute pain, right, there is the risk of re-injury, right? But with chronic pain, oftentimes that's not the case. But there is that fear that our behavioral health specialists have of like, well, I'm not really sure what the limit is. Like, is this a risk or not? Like, should I be telling them that motion is lotion and keep moving, right? Should I do those things, or should I be telling them to rest and recover because this is a real injury? Like, that kind of confusion is very real and scary. And so, yes, we talk a lot about how to consult with the medical providers and like ensure that this is a certain type of pain, and that, you're right, and there's no surgery is not going to be helpful. This is chronic pain, and there's, those factors going on. So it's a really important aspect, Matt. I encounter that a lot.
Yeah.
And also,
go ahead.
sorry, hi, it's Dr. Ned. And I think also, like you guys were saying, like, also not just utilizing the pain meds, but like you were saying, utilizing alternate interventions like the dancing, the physical, also the nutrition aspects of utilizing different interventions to decrease the pain. Those are also different interventions that we should discuss with patients, because they often don't know, like the deep breathing, the physical activity, those types of interventions. Those are also helpful as well.
I was just going to say that, everything we're saying is such a wonderful argument or support for primary care behavioral health integration, right? Being able to literally walk down the hall and consult with the providers who might be able to advise on a person's physical ability and potential for reharm. And then at the same time, coaching patients to help empower them to seek out those answers for themselves. Let's get actual, instead of us wondering, like, I can't, or assuming that I can't, let me go learn and then listen and reincorporate this new knowledge. After I've spoken to my provider, my physician says that it is okay for me to do some moderate exercise given the pain that I'm feeling, and we can reinforce that and push it forward. But I want to also make sure that they're feeling empowered to take charge of that for themselves instead of just always relying on us to give the clear and go ahead. I think doing that helps. It pays dividends down the road for them.
I think it's great. A lot of the, you unknowingly answered our next question that we were going to ask about interventions. I wanted to kind of change it up a little bit. But I think it's really helpful to hear a lot of more of the specific interventions that you all were sharing, which is great. But in thinking about, working within kind of at the PCP level or more at an organizational level, what challenges have you experienced in implementing more of a biopsychosocial approach to addressing chronic pain?
Well, so in my site, just to reiterate, so I work in a family medicine residency. So my office, the room that I do my therapy in, it shares a wall with the patient room, and there's 20 of them in our office. We have 40 physicians that cycle through. So I'm interacting with a lot of different providers, and we have a number of other healthcare professionals too: social work, nutrition, consulting psychiatry, et cetera. And so the availability is there, and because we're the family medicine residency, we're able to, I'm in the position to actually train the residents to learn this information as well. And that's just baked into their curriculum as a residency. So we have a little bit of a unique scenario that others may not have, but I'll say that because we have it, we take advantage of the opportunity. And so from day one, the residents are getting immersed in this side of healthcare, right? That they may not otherwise. And so the challenge that I face is just whether or not they want to embrace the behavioral health perspective. But what's neat is, especially with something with chronic pain, the stuff that we have to offer does have a real impact, and it can be done extremely efficiently. So a physician who may feel like their hands are tied because they can't prescribe those meds due to restrictions on certain medications, right? Now they feel like they actually have something they can offer their patients. And whenever they need it, they can literally come down the hall and come grab me, and I can come in and talk to them too. And once they start to see that, the challenge starts to evaporate, and they can actually feel more empowered and like they have something to offer their patients who are coming in again and again and again, complaining of pain, but feeling like their physician isn't able to help them in the way they want to be helped.
And I'm just waiting with bated breath for our organization to hire all of Mark's colleagues when they get licensed and have this outlook, because serving in a leadership role and meeting with other organizational leaders, both on the clinical side and the operational side. For some context, our organization on our Medicare business is using value-based contracting. And so we're assuming the risk of the care of our patient. And so not only are we clinically wanting to improve their pain, if they're getting 10 injections a year and an unhelpful back surgery, we're on the hook for that financially. And so there is actually a huge overlap with the operational leaders and the business side. We've made a very strong business case, and I'm going to give hats off to Dr. Hallstrom for doing that, because she'd never give her own tip of the hat, because we made it abundantly clear this is in the best interest of the organization. And so the challenge is not putting my head through a wall when we continue to see stagnant progress and really expanding this and making this second nature. And I think just to remember that this is a competing interest of the many things. These are our patients are coming in with pain, but they're coming in with 8 other chronic conditions that they need referrals and things for. And so being empathetic of all the things our clinicians are juggling. But I think that's why I'm so excited to dive into Dr. Hunter's work. I'm so grateful for Kirsten's work, because the more we can just make it easy, like Mark was saying, and have our providers see that this is worthwhile and actually involves less work for them, because we'll come take that handoff. We'll make that happen. We'll close the loop. This is beneficial. We believe this is good, even if the patient's a little angry and resistant, and just wants to go get their injection like they've always gotten. To kind of have that conversation of pivoting. I think the challenge is just continuing to know how to sell it as a clinician leader on why it's clinically beneficial, but also making the business case, which I think is very strong, especially in a value-based setting. I think even in a fee-for-service setting, just in the name of making healthcare more valuable and worthwhile. A lot of these interventions that people typically get just are really high cost and low yield. They just aren't sticking. And I think that that's just a challenge, is keeping the motivation rolling, and really believing in the business case, and getting buy-in from the organization at large.
I think one of the difficulties I see with the biopsychosocial approach that is still not working well is that the medical community is still very siloed. Even if our providers recognize, like, oh, they need to go to physical therapy and they should go to a pain clinic. Oh, and they should see, like, they're sending them to these places that don't all talk to each other really. And the problem with that I hear from patients is that patients feel like the buck keeps getting passed. They are the person getting shuffled through to all of these specialists or all of these people, but each time they explain what's going on, they just say, oh, you'll talk to the next person about that, or you talk to the physical therapist about that. And it's still really siloed. And the problem with that is, one, yes, the patient experience, but two, there are real life things that come up that are really hard for them. I mean, a patient that comes immediately to my mind, I have this woman who was injured a little bit less than a year ago. She's already had 2 surgeries on the same body part, and she is now signed up to have a 3rd surgery in the hopes that this works for her. And she has the ups and downs, but she sometimes calls me sobbing daily because the pain is so excruciating for her. And I mean, I feel terrible for this person. And so her next surgery that is supposed to be coming up, after that surgery, she's supposed to go to a skilled nursing facility for 6 weeks to rehab. And she is actually considering not doing any of it because she doesn't know what to do with her dog. And her dog is her life. Like, that dog is the reason she is still alive today. And so, very valid. Like, what is she going to do with her dog? And like, I'm at my wit's end trying to figure out what to do with her dog, because no one else wants to figure that out. The surgeon doesn't want to figure that out. The SNF doesn't want to figure that out. Like, no one is willing to approach this from a social perspective of like, what is the reality of actually what she is facing on a daily basis? What's important to her? What are her values? And how do we navigate all of this? So I am so grateful that we as a medical community are trying to figure out how to integrate things, but they're still quite siloed. And it's really easy to push things like that off when it's not that person's, specialty, or it's not their scope of practice or whatever. And so I think that's the barrier I see, is that, like, even though the understanding of this biopsychosocial approach is improving, the implementation of it still needs a lot of work.
I wanted to chime in with a comment from our chat. You mentioned, Dr. Hallstrom, that sometimes patients feel like, they're just kind of being passed on, right? People that, struggle with patients with chronic pain and they just want to hand them off, right? Dr. Hunter in the chat mentioned that it's also important for PCPs to learn, right, how to be a good salesperson, so that they can sell these interventions, but also understand how to do them themselves with the patient, so that, my mind thinks that maybe this will help with the patient's feeling of they're just being kind of passed on. Is also, when we think about BHC, we are also educators, right? So we can help work or help our PCPs work more effectively with these challenging patients, rather than just kind of passing them off to us. Yes, we're a great resource, and yes, we want to be utilized, but in other settings, PCPs may not always have access to a BHC. So part of what we want to do is also help work with the PCP so that they learn how to work with these patients and provide those psychosocial interventions themselves.
Oh yeah, absolutely. I mean, that's why programs like Dr. Cassano's are great, where he's actually like teaching residents and telling them how to do some of these interventions. But you're right, not everyone has access to that. And I will say, even the programs that do have access to a BHC in the clinic, medical providers are doing so much throughout their day. I mean, their visits are just back to back to back, and they're short, and they're just trying to get through the day a lot of the times. And they're doing their due diligence, but my goodness, if they can just hand that to a BHC to take care of, that's great. But that still doesn't teach them like how to do that intervention, how to have the patient feel heard and understood in the visit with their doctor, when a lot of the times the patient doesn't want to go to the BHC because they want to see their doctor, and they're not their doctor to solve this. So you're right. I mean, we need to get more to the root of the issue, is like really helping teach these providers and like systematically giving them time to do that, which like could be its own whole panel discussion for another day. But yeah, there's lots of things we can definitely work on.
All right. Well, we have about 3 minutes left. I want to be mindful of time, so I want to just quickly open it back up to our attendees, if there are any, or panelists, if there's any final reflections, questions, comments about the discussion that we've had so far, before we wrap this up.
I'll offer just a brief bit of wisdom for those who are as scared as I was when I first started this, or who are frustrated that they feel, feedback we hear from our teams a lot is, well, no one's sending me chronic pain referrals. Well, they might have not sent you the patient because of chronic pain. Get curious. Ask them when you're doing an intervention for depression. Hey, you ever notice that when you're really down that your back hurts more? And just see where it goes. You get to kind of conceptualize and plug that in, especially if you're just getting your feet wet. And maybe the intervention takes a turn and really stays very mood focused. Know that that's still a pain intervention. We know that the hormonal response of a chronic depression is going to increase pain perception. So by improving the depression, you are doing chronic pain intervention. You might not be doing it explicitly, but you're probably doing this more than you already think. So for those who are new, those who answered in the chat like, I don't know what I'm doing, that's a daily experience for me. So go back to what you know and recognize it's having an impact, and then just go one little degree. Just say, what are your thoughts around your pain? Just good cognitive reframing, the skills you know you have. Just try adding that with the pain focus and see where it goes. Seek some consultation, check out resources. You'll find that you have more skills of this than you probably realized.
That's great. Thank you, Matt, for sharing that. All right, so thank you everyone so much for attending, and thank you to our panelists for dedicating this hour of their busy schedules to provide this valuable information to our PCBH and CFHA community. Just as a reminder, our next meeting is going to be August 7th, same time, and we will have another panel discussion around obesity management. So we hope that you guys will join us. And as a reminder, fill out those mentoring surveys and those feedback surveys. They help us, and they inform what we do, how we can serve our community. All right, you guys have a great day.